Hello and welcome everyone. So I'm just disappointed I missed all the dancing last night, because anyone who knows me knows that I would have been on the dance floor till the bitter end. So thank you all so much, Anne, for the invite to come and talk to you all today. It's been an absolute pleasure, and Numan is very sad to not be joining. Unfortunately, the clinical needs for the staff, unfortunately, took priority, so I do apologise. So I'm coming to talk about radiotherapy. Why do I think that I'm potentially the best person to come and talk to you about this? I am a senior lecturer at Sheffield Hallam University, so I get to read lots of research articles specifically into radiation therapies and how they are dominating, specifically when it comes to immunotherapy and radiotherapy at the moment. I also link with lots of other cancer charities, and I've also had cancer myself. So I feel like I absolutely can empathise with all of you in the room who have had that conversation with that doctor at that time. Numan is also a therapeutic radiographer. He works as a research radiographer at the Royal Marsden Hospital in London, and he also works 2 days a week at Macmillan as an AHP clinical advisor. And he is multi-award winning. So between us, we've got quite a few awards, but Numan is currently the AHP of the year and has won 7 awards this year for the work he's doing within health inequalities. So between us, we make a good team and we're very supportive of each other. Obviously, we do run RadChat. So RadChat is a podcast and social media channel. For anyone out there who has had radiotherapy, put your hands up. Goodness me. Well, I'm talking to the experts in the room then. It is one of those treatments that maybe you hadn't heard so much about prior to actually receiving your treatment. If you go on and Google radiotherapy, the information can sometimes be quite confusing. As with all medical professionals, we love to use an acronym, and that in itself can be really confusing because different types of radiation treatments, different types of radiotherapy techniques, every single one of them has a specific acronym that we like to use. And that can be really confusing to actually decipher what it is that you as a patient are going to experience. I think one of the big things to kind of be aware of is just the varied nature at which people present or potentially go back through the radiotherapy pathway. Obviously, you will all have your own individual journeys. I think one of the things that we definitely see within radiotherapy and oncology is the fact that radiotherapy can cause side effects. And as a consequence of that, those side effects can sometimes be also reoccurrent symptoms. And that sometimes can really make it quite difficult for us as therapeutic radiographers and doctors to be able to support our patients to ensure that actually we're deciphering what is a side effect and what is potentially reoccurrence. Obviously, radiotherapy is utilised quite significantly now within cancer care, but it wasn't always that way. And actually, when we look right back to where radiotherapy originated, it was in 1895 when it was first discovered by William Röntgen and Marie Curie, and they essentially just found it by accident. And when we think about it now, how we use X-rays, and how many of you in the room would have had multiple X-rays, CT scans, MRI scans, the real kind of start of radiology really did start there. This is one of the first ever linear accelerators up on the screen there. It literally was a case of manoeuvring your patients underneath what we call a linear accelerator. Very archaic. And actually, in terms of kind of the actual feasibility for radiotherapy, it was quite complex treatment, and people were kind of basically just thinking, this is a last-ditch attempt, let us see what we can do for some of these patients. And as you can see through the years, these have absolutely progressed so that we're able to harness and use these X-rays in a much more targeted way and reduce the radiation damage to any normal healthy cells. So we are much more targeted with where we are actually trying to pinpoint, whether that's where the cancer is or where it was previously, if that patient has had chemotherapy, immunotherapy, or surgery previously. And we have here little MLCs. So they're the multi-leaf collimators that sit in the head of our radiotherapy treatment machine. And they are essentially what is targeting all of the radiation, but conforming it specifically to the area that we want to treat and minimising that dose as much as possible. I think when you say radiation, people go, doesn't that cause cancer? Is that not dangerous? And absolutely, too much of it is an issue. But we really do harness the technology and the software to be able to pinpoint exactly where we're aiming at. The latest technology in the last 3 years has been absolutely incredible. The use of AI in radiotherapy and radiation treatments has significantly improved some of the outcomes for our patients. We have on the left there something called an MRI LINAC. So I'm sure lots of you in the room would have had an MRI scan at some point in your lives. And what we are trying to do now is utilise the really beneficial imaging that MRI provides and mix it with a linear accelerator. So there's currently only one in the country, and it's something that a lot of departments are literally fundraising for to be able to get them into their departments, because we know that we will get superior outcomes if we have better imaging. We can reduce the normal healthy tissue that we're treating if we're able to identify what is inflammation, what is actual cancer, and being able to really target much more precisely is going to benefit us. We also have proton therapy here in the UK as well. So proton therapy is essentially a different type of radiation treatment. It basically has some nice physics principles behind it, which allows us to be able to deliver higher doses with the potential of not causing any long-term side effects to specific areas. So quite often proton therapy is used for paediatric patients, but there is currently a trial going on in London at the moment looking at proton therapy for breast cancer, and also we have a trial in the UK looking at proton therapy for prostate cancer as well. It's used quite a lot in America. I would say that's largely due to funding. So, you know, if you're going to compare linear accelerator, external beam radiotherapy and proton therapy, the research doesn't necessarily indicate that it's better prognostically for patients, but because the consultants can charge more, I'm sorry to sound very cynical, but I think the evidence speaks for itself when you maybe see some of that. So I would be really careful when you're going online and reading about radiation treatments. Just look, is it from America? Because I don't necessarily think it always gives a true representation of what is clinically significant. We also have CyberKnife as well. So for anyone who potentially might have followed the podcast You, Me and the Big C and followed Dame Deborah James, she actually reported her CyberKnife treatments, and we got lots of engagement with our patients specifically to talk about it. It isn't available in every radiotherapy department, but it's essentially like a robotic arm that delivers really high ionising radiation, but is very much more targeted for tumours that potentially move. So if you had a tumour in your abdomen or your chest, you know, normal breathing, normal gut changes potentially can move tumours around quite a lot, whereas CyberKnife is able to kind of mechanically move the arm of the linear accelerator and actually target that tumour much more precisely. And again, you know, it's not something that's necessarily offered everywhere, and the eligibility for it is usually for secondary metastases. And then we have the gamma knife, and I'm going to talk a little bit more about the gamma knife and stereotactic radiosurgery a little bit later. And that's largely because it is a treatment that I personally would advocate for people with brain metastases. And I will go into a bit more detail about that later. So radiotherapy is really high ionising radiation. So when you consider you go for your normal plain film chest x-ray, we're using big radiation compared to that. So 1,000 times more powerful than your normal x-ray. And what the aim of it is specifically to try and target where the cancer is or where it was if there's any microscopic spread, which is why for a lot of breast cancer patients, they will have it as part of their treatment pathway. To ensure that any cells that are left over, we're able to eradicate as much as possible. So how does radiotherapy work? I promise you I'm not going to give you a radiobiology lesson. I think my students, their expression tells me everything I need to know. But I also don't want to patronise you. And actually it's really important that you do know what's going on in your body and how the radiation is effectively working. So when we have cells, essentially, that are then that we then direct the radiotherapy at very specifically, what is happening is either direct or indirect action. And essentially what I mean by that is the radiation is coming into the cell and it's either directly damaging the DNA, so it will break the strands of that DNA. I think it's perfect that your logo for the Patient Summit has the DNA helix on it. Perfect for me to describe this. But essentially the helix will be broken and therefore that cell will be damaged enough so that it can't go on to then replicate. We also have then indirect action, and that's where the radiation will effectively cause a reaction within the cell, specifically the H2O, so the water content within that cell, and that will produce free radicals, which will then go on and do exactly the same as direct action and will then impact on the DNA. So 2 types of radiation damage. One thing to be aware of is obviously, the fact that we need to be well hydrated with water in our cells to make sure that indirect action can happen, and also thinking about hypoxia. So hypoxia is essentially a word that means lack of oxygen. So if you have a tumour specifically that might be categorised as hypoxic, that might mean that radiotherapy is not going to be as effective, because we absolutely know from the research that if you have hypoxic cells, it takes longer for radiotherapy to kick in. And there may be other treatments that are more beneficial than radiotherapy. 40% of all cancer patients are cured by radiotherapy. But actually, some of the statistics are really shocking about the lack of access to radiotherapy. I work really closely with a charity called Radiotherapy UK, and we petition a lot at the Houses of Parliament to really get investment in radiotherapy. Because as all of you in the room will know, radiotherapy is not available at every cancer centre. There's about 74 radiotherapy departments in the UK, so there are long travel times, and I can't think of anything worse than having to get up, travel 2 hours, sometimes 2.5, to your local radiotherapy department for essentially a 10-minute appointment, if it's running on time. Yeah, exactly. Getting parked, honestly, and we recognise it as staff. I speak to patients day in, day out, and the thing they always say is, how do you cope with parking? Because it is absolutely ridiculous. If the government could sort out anything, they need to sort out parking for patients and travel. But because of that lack of access to radiotherapy departments, sometimes it isn't the treatment choice for you, which is really frustrating for us because we know that radiotherapy can be really beneficial, especially if you are having treatment for bone metastases, brain metastases. So it's something to kind of be aware of, and obviously if you are writing to your local MP at any point, definitely throw in about access to radiotherapy. We need to make it much more a topic of conversation. Also as well, thinking about kind of access specifically to maybe more specialist treatments, like I mentioned, stereotactic. It's even fewer departments that actually offer stereotactic radiosurgery. So again, something to kind of be aware of. Now, there are other treatment modalities specifically within radiotherapy. So the one using the linear accelerator is called external beam radiotherapy. So that's the big machine that I'm sure a lot of you had experience of. We also do use brachytherapy, so that's where we would do internal type of radiation. So that's usually using a radiation source. It's not typically used for breast cancer or secondary metastases, but sometimes some private departments will utilise it as kind of an intraoperative kind of radiation. We then do things like radioisotope, intraoperative, and also proton therapy as well. So some of the terminologies that you may come across if you're doing some research on Google, although as a healthcare professional, I wouldn't always advocate it, but I know you do it. So radiotherapy intent. Obviously, 60% of all our cancer patients that come through radiotherapy are receiving radical radiotherapy, but it is highly effective for secondary metastases. This is actually a patient who had a mesothelioma, which is a type of lung cancer. And as you can see from the top image to the bottom, we weren't able to cure that patient, but we dramatically decreased the size of that tumour within only 2 days. So it really does show the response that some tumours will actually have to radiotherapy. So this patient had coughing up of blood, they were slightly breathless, and they had a lot of rib pain and a lot of pain on movement. So obviously, we're thinking about quality of life and making sure that the patients aren't in pain, and especially for bleeding, radiotherapy is really effective at ensuring that these tumours don't bleed excessively and can obviously shrink it. So we're not always necessarily looking about kind of length of life, but it's more about quality of life, living pain-free, living without, your quality being impeded. So this is a closer-up picture of the linear accelerator and one of my lovely colleagues from Nottingham. And he's just using what we call the pendant there. And I thought it was really interesting because a lot of the time you're on the couch. You don't get to see what we're doing around you, and it's so frustrating, especially in radiotherapy because the lights are dimmed. I'd like to say we give you a nice atmospheric experience. I know that's not what's happening in your heads. But absolutely, take in your own music. Ask for the lights to be on or off. If you're cold, tell us. We'll put a blanket on you. But obviously, from our perspective, we would get you to lie on this very hard couch. You may be on what we call a breastboard, where, if you are having maybe anything to the thorax region, potentially we would sit you up ever so slightly, or we may get you to lie down. The board and couch are really hard, largely because we need the radiation to be able to pass through it without it being interfered with. And that's essentially why. We'd love to give you a nice soft mattress. That being said, if you did have something like spinal cord metastases, we absolutely can do things to try and help you with your positioning. The key for us is what we call accuracy and reproducibility. We want to be as accurate as we possibly can be. And typically, we are within 3 millimetres of accuracy when we're trying to treat. So, we're quite OCD about where we're going and what we're doing. And that's sometimes why we compromise your comfort. So I promise you it's not because we're narcissists, I promise. It is just because we're trying to get that accuracy as much as we possibly can do. And obviously, if we stuck you on a nice, comfy mattress, you might just wiggle a little bit. And that's inevitably why we always ask you to stay still. And you would have heard that time and time again every time you went out of the room. We also have a type of radiation treatment called electron treatment. And that's essentially where we are using electrons rather than photons. And electrons are a bit more superficial. So again, in the room, some of you might have had an electron boost. And that's because we're targeting tumours that are maybe more situated superficially. So by that, I mean on the skin surface or just underneath in the lymph nodes. And it's because the X-rays aren't quite so penetrating in the form of electrons that we can target those areas a little bit more precisely. So to actually deliver radiotherapy, we do need a CT scan, and that's so we can do all our physicsy dosimetry bits. So we use basically the Hounsfield units that are generated from the CT scan on that picture. So if any of you have seen your CT scans, you'll see there's little pixels. I always think of it as Lego, okay? So in Lego, if you take one block out, you can kind of see, well, where does that go? What does it do? How does it differentiate? And exactly the same with our CT scan, made up of lots of Lego, and what we want is to identify how much dose is going to every single block of Lego. And it's that precise. We want to be able to conform exactly to where we're going, and that's why we use the CT scan. Whatever position you are in for your CT scan, that is the same position that will be replicated for your radiotherapy. So please, please, please get comfy here. This is your time to really go, no, I'm not comfy. No, that's pulling. No, I need a blanket. Absolutely. You need to ask all these questions at this point here so that you know that when you then go for treatment, you're going to be in a comfortable position. And things obviously change, so we always say as well to the patients, if you can time things like pain medication before going for radiotherapy, it can sometimes help, because then when you're in that position for an extended period of time, just to be aware. Usually it's about 10-15 minutes. We're quite speedy. But that being said, depending on the complexity of the setup or maybe your mobility, it can take half an hour, 40 minutes. So it's just something to be aware of, that it can vary. This is the radiotherapy position that I was talking about. So I'm sure that will be familiar to lots of you in the room who had radiotherapy for primary breast cancer. That's with the arms up to make sure that we're trying to avoid this long bone here. And then as you can see on this side here, we have different accessory equipment. And that's largely to keep you nice and still as long as we possibly can do whilst you're in the radiotherapy position. So we have lots of little accessory equipments. Put your hands up if you've got a nice little tattoo somewhere on your body. Yeah. Now, I absolutely know for some of you, it's like, this is me, and this is the tattoo that kind of signifies what I've had to go through. For others of you, you will look at that and it will be a reminder that you really don't want. Just to be aware, you can get them removed. So it is something to kind of think about. Some trusts where you actually had your radiotherapy do it for free. So if it is bothering you, I would really, really get you to have a chat with your team to see if that's something that you want to explore, because it is really important. And there's lots of research now around the psychological impact of having these radiotherapy tattoos. The reason we use tattoos is essentially a way that we can line you up precisely. You know how I said that we are within 3 millimeters of accuracy? To be able to do that, we do need to have these tattoo marks, which then align with these permanent lasers. So it's basically an X marks the spot. One thing to be aware of, if you're thinking, why are they lining me up down here and I'm having treatment up here, don't panic. The bed does move into the right position once we've got you there. But again, that can sometimes be distressing for patients. You know, when you're lying there and you're totally kind of giving your faith to the staff, and then you're thinking, why are they doing that? Do they know where they're going? I promise you, it will be because we're moving to a specific point, and you can't always necessarily feel the bed moving. But any doubt, please make sure you ask the team. We love to chat. As therapeutic radiographers, we love a chat. And as a consequence of that, any questions you have, ask away. I know we tell you to keep nice and still and breathe away normally. That's not to say that if you have any concerns at all, that you stop them and say, actually, I need to ask this question now. If it's concerning you, it's far better to ask it then than you lying there for 10 minutes thinking, oh my gosh, I should have asked that question. Have they done it wrong? You know, don't let that be the experience that you go away with. The one amazing development that has happened in radiotherapy now is something called surface-guided radiotherapy. So this is where we don't need radiotherapy tattoos. So this is essentially using an optical detector of the skin surface. And what we're able to do in quite a few departments now, it's still not everywhere, but largely due to funding, but you can request to go to another department if you have a preference for maybe some of the radiotherapy techniques. But this is essentially a way that the patient can be set up purely by the contours of the skin. So if you had an abdominal type of tumour or any metastatic spread in that area, then potentially that is an area that we could treat utilising surface-guided radiotherapy to get you into the right position. You'll also see as well, these are fancy kind of panels that come out of the side. You might have remembered that they would occasionally come out, but not on every treatment. That's essentially our imaging. So what we're able to do now is take a CT slice of where you are sitting or lying every single day as part of your treatment, and then we're just verifying that and checking it against that CT scan that you had in pre-treatment. So it's just another check-in procedure, really. Radiotherapy planning is the bit out the back that nobody gets to see. but essentially it's highly complex. There's lots of computer software used, but quite often it will be the oncologist, the consultant therapeutic radiographers, or the planning staff and the physicists that will essentially plan your treatment. And this is why you don't always necessarily have treatment straight after your CT scan. Sometimes it can be a bit frustrating. You go to the radiotherapy department, do your CT scan, and then they say, right, 2 weeks later, come in. That can be quite frustrating, but it's because all of this is going on in the background. One thing I would say as well is if ever you were diagnosed with a spinal cord compression, or potentially if you had an emergency situation where maybe you had some bleeding somewhere that needed radiotherapy, you would be classified as an emergency patient and you would have CT and also treatment in the same day. So it's much more effective when we come through on the department. We typically operate Monday to Friday in the radiotherapy department, but we do treat essentially during the weekends on call. Now these look like pretty colours. And they are pretty colours, but this just shows you some of the dosimetric things that we are doing when delivering radiotherapy. So this is actually a breast cancer radiotherapy treatment plan. So again, somewhere in your patient notes, hidden away, there will be copies of your radiotherapy treatment plans. And essentially, this is a way for us to be able to look at where that radiation is actually targeting. So for any of you who have late effects of radiotherapy, I always advocate, ask to see your radiotherapy treatment plan. You know, for anyone you know who's going through radiotherapy, ask to see that radiotherapy treatment plan. It's essentially a map of where is receiving that radiotherapy, and you can then align that to, well, actually, I know I had radiotherapy that came up quite high. A lot of the time when we do breast cancer treatments, people think we're just targeting breast tissue or chest wall. And actually, it's not necessarily the case. We sometimes come quite high up into the supraclavicular fossa nodes up here, or right over to the side in the axilla. So as a consequence of that, it's really important to see this. It's like that Lego that I was talking about, seeing where on your body that radiation is actually delivered. Now, these are some of the acronyms I was talking about, just a few of them. We talk in very weird ways in radiotherapy, but essentially, for anyone who's maybe going through radiotherapy or in the future, you may hear some of these terminologies. Intensity modulated radiotherapy is essentially, as I've said, we're trying to modulate the dose as much as we can do across the area that we're treating to try and normalise the dose to normal healthy tissue. A new type of treatment called volumetric modulated arc therapy is called VMAT, and that's essentially where the linear accelerator rotates around you at the same time as delivering. So it's like an arc treatment. Again, it's all around trying to get the dose to where it needs to be delivered and avoiding that normal healthy tissue. Sabre. Anyone heard of Sabre before? Yeah, a few of you. I did think it might be something that people would recognise, largely because it is a treatment now used quite a lot for metastatic disease. And Sabre is essentially external beam radiotherapy, but it is delivered in much higher doses and much more conforming to certain areas. So if you maybe had 3 or 4 different sites, we could deliver Sabre to essentially ensure that we're trying to minimise the dose as much as possible. There are quite strict eligibility criteria, but it's definitely something to think about. And one of the techniques as well might be deep inspiration breath hold, which again you may have experienced going through primary breast cancer, but it's something to be aware of that DIBH can also be used specifically for maybe abdominal tumours as well. And what we're trying to do is mobilise the tumour as much as we possibly can do, mobilise that area so that we can essentially pin it down so we can deliver the treatment. So I'm going to rush over this just because I am aware that time is ticking. One of the resources that I heavily advocate is the Northern Cancer Alliance patient information videos. They have essentially developed videos that go through the consent process and talk about all the side effects. And usually you might get a little leaflet or you might get your consent form. And your consent form, quite rightly, is much more detailed than it ever used to be. But if you're anything like me, my consent form went in the bin straight away after I'd signed it. So, you know, thinking about side effects and what you're going to experience, this is a really good resource that I would suggest you check out. So radiotherapy, as I've said, is hugely beneficial for bone metastases, specifically to try and address pain. Anyone who has bone pain now, you will know it's insufferable. It's one of those pains that like a toothache that you just can't get rid of. You know, from an analgesic perspective, it can be really challenging to manage. And what we want to do is make sure that we're not just upping your analgesics. So actually, radiotherapy is a really effective treatment modality to utilise for bone pain. And so once diagnosed, we can really work our magic with our radiotherapy. Now, I talked a little bit about gamma knife. So gamma knife uses gamma radiation, so a slightly different type of radiation to what the external beam radiotherapy uses, and it's a live source. It's actually tiny, like I've seen it. It's like this size, and when it comes in a massive armoured vehicle to the department, you're like, oh my gosh, and I was envisaging it was like this massive ton source. No, it's absolutely tiny. And it emits this radiation that we use for stereotactic. And as you can see on some of these images here, I apologise, I couldn't find any great images. But essentially what happens is we will use a frame or a mask, and this is specifically for brain metastases. And then what would happen is we would do really intense imaging. So usually we do PET, we do MRI, we might do some angio with contrast. So some of the images up here, and we would essentially target those metastases as precisely as we could to deliver lots of dose. So it's just something to kind of be aware of. If you are ever referred for whole brain radiotherapy, ask the question, could I have stereotactic? Some oncologists aren't necessarily aware of it, or they're not specialists in it because it's not in their hospital. That doesn't mean that you're not eligible. And that's just another image there, kind of depicting how those small little beams can be used to treat. Side effects, please keep your consent forms if you can. And also the Society College of Radiographers offers some amazing resources, specifically to help you with skincare advice upon having radiotherapy. Long-term side effects. You can develop long-term side effects from radiotherapy, sometimes 5, 10, 15, 20 years later. And again, it's just something to kind of be aware of. If you're experiencing symptoms, could it potentially be a radiotherapy side effect? So what can you do for yourself? So absolutely, I'm sure you've heard about the recent research that came out about exercise. If you could, do a free prescription for exercise or physical activity. I sometimes get annoyed when we say exercise because it makes you think you've got to run out and run 5K, which is definitely not achievable for a lot of us. But things like, actually, can you get some tin of beans and raise them over your head? Are you all doing your shoulder exercises? If you're not, the physios who gave that information on your surgery will be like turning in their graves. You need to make sure you do them for life. Brushing your teeth, 3 minutes a day. Do those exercises. It will have a big impact on you. And also, if you are going for radiotherapy and you're nervous, check out RadChat and what we've got, and you're always free to offer ask any questions. Just to be aware, we have just launched an image library to try and help address health inequalities. It's the first in the UK where we are crowdsourcing with patients to share their images of radiation reactions, immunotherapy, SACT changes to the skin, because if you Google radiotherapy skin reactions, guess what comes up? White skin. So we are hugely trying to change the educational model out there by using this image library. So if any patients would like to contribute, we would be more than happy to help and support you in doing that. But essentially, this is going to help train the future healthcare professionals working in radiation oncology. And I know I've talked a lot, so I do apologise, but that's all I have, and thank you very much.
Let's sit down over here. Hello? Thank you. That was absolutely fabulous. I learnt a lot. Thank you so much. So informative. I wonder if I can start, while people start raising their hands and our roving mics can go around, by asking you about where does AI fit in all this? Because everybody seems to be having AI now in everything.
I love to talk about AI, largely because we've actually used AI for 10, 15 years in radiotherapy. You could almost say it's old hat for us. But essentially, back in the day when I first qualified, when we had your CT scans, we used to have to contour around every single organ, so on every single CT slice, so that we could work out the radiation dose. Now, AI, literally, for some softwares, it's a second, and it will outline all of these contours, outline where the tumour is. So you can just tell that actually it's sped up that process. So rather than maybe a month in between the CT and starting treatment, it's now typically about 2 weeks, but for some patients it can be less. So AI is absolutely imperative for us to harness, to be able to speed things up with accurate human interaction to check everything. You know, we would never rely on software inherently just to do everything and then take it straight to treatment. But also whilst we're on set as well for matching images, specifically to make sure of positioning and accuracy.
Thank you. Questions? Could we have some mics to the centre and also to Lesley, please? Is there a roving mic? Yes, thank you.
Hi, Jo. I'm sure a lot of the patients in this room will have had or have brain mets. And I just wondered how much whole brain radiotherapy is now used versus the more targeted treatments you talked about, because I'm aware that I think in Scotland the guidelines are very different. And I think if you've got, I think you can only get the more targeted radiotherapy if you've got 2 brain mets.
Yeah. Yeah, there are lots of variations in practice, and obviously oncologist preference as well. I would always say to ask the question, and I'm sure lots of presenters have said that, but asking the question can stimulate that discussion. Obviously, there are private centres now as well that offer stereotactic radiosurgery like Amethyst. I'm not partnered with them. I just know that actually, you know, you are within your rights to go elsewhere should you need to. But yeah, variations in practice quite substantially.
Thanks. There's some questions over there.
Is there a limit on how much radiotherapy you can have?
Perfect question. Love that question. Yes, there is. So every organ, every tissue in our body has what we call a tolerance dose. So that essentially means that for every part of the body, we will have a recognised amount of dose that we can deliver up to. And, you know, some parts of the body can receive more dose versus others. So things like ovaries are very sensitive to radiation, whereas things like actually our brain is quite radio resistant, our liver radio resistant. So as a consequence of that, we typically dose escalate, so we deliver higher doses. So what would happen is if you've had radiotherapy previously, we would look at what the dose was that was delivered, and then we would ascertain, can we also go above and beyond to essentially ensure that we are keeping within those tolerance doses. What we don't want to do is deliver too much dose that we damage that normal healthy tissue, because then you're going to set that patient up for long-term side effects, necrosis, which is essentially like the death of the cells.
Thank you. That's an interesting question. So actually, could we have this patient here first of all? Sorry, I don't know all your names. You know.
Is this on?
I've tried.
Oh, yeah. Someone asked this, or Carla mentioned this last year as well when I was watching online, but in relation to stereotactic therapy, I wasn't able to have it because I was de novo, which I thought was very unfair, and it took a while for someone to actually explain that I was excluded just because of de novo. And I know last year, Carlo said that there was some oncologists were hoping to challenge that because it was only based on one study or something at the Marsden, that it wasn't... There was no overall sort of survival improvement. I'm just wondering if that has been challenged. Sorry, Carlo, I just thought you had said it.
There's some interesting debate going on in the front here about that. Maybe we could come back to that. Could we have a microphone, please, to Marina? Thank you. Pass the baton.
I think you get the prize for the best question.
I
So I think the question is about
If
de novo. It's about synchronous versus metachronous, and the fact that we use currently Saber's only commissioned for metachronous, not synchronous, and that's because of the data. But I'm going to give that to my.
Let's Dr. Jill Bishop explain.
So I'm a clinical oncologist, which means I use radiation as well as systemic therapy. At present, NHS England is that you have to have less than 3 or less metastases. You have to be more than 6 months since your original diagnosis, which means that you cannot, frustratingly, use it for de novo disease. And that has not been changed, although my clinical oncology colleagues, some of them are trying to challenge that through NHSE, but that's why.
It's just that's so unfair.
I don't my personal opinion is I don't disagree, because there's some interesting data around the survival of de novo disease in comparison with metastatic disease, particularly metastatic disease that has occurred within a couple of years of treatment. But you,
Yeah.
you can ask, so you can use partial brain radiotherapy. I don't particularly use much whole brain radiotherapy, to answer that question earlier, really because of its toxicity, so I tend to use partial brain radiotherapy.
Thanks very much for that clarification. If we could just have 2 quick, short questions there
One quick
and
question.
down here.
It's a conference that's coming up.
Carlo, the time is up, so can we...
One quick question. It's a problem that patients are facing, so it's a practical issue. So
Yes.
women who've had brain mets treated, we now have radionecrosis. So Joe, how, as a clinical therapeutic radiographer, do you deal with that, and what advice do you give to women, because it's an increasing problem?
Yeah, so there are late effects clinics that are now run by therapeutic radiographers, and I would suggest that you go and seek that help and advice, and they will offer all the support that you need. It's quite a big wraparound care, but yeah, it's not, thankfully, as prevalent as it used to be just because of the techniques that we're seeing.
There, and then a quick one here, because Carlo took up your time with
you.
a very interesting question.
Hello, thank you very much. I have brain mets and I've had CyberKnife. Could you explain the differences between gamma and CyberKnife and why one would be used over the other?
Yeah, so sometimes it's about what you've got access to, which I know it shouldn't necessarily be, but it is the realities of it. As well, it depends on how many brain mets you have. So clinical criteria specifically might be determined based on that. But essentially, it's doing the same thing. So, it's much more precise, and it's targeting much more precisely where it is without irradiating normal healthy tissue. So whether it's CyberKnife or stereotactic or Saber radiotherapy, the aim is all exactly the same.
One last final question.
Thank you. Has radiotherapy ever been used for peritoneum, cancer on the peritoneum?
Yeah, it depends on essentially clinical criteria and specific personalised information, I would say. I don't know from the oncologists in the room whether they'd kind of... Yeah.
Sorry, I've only seen it used once. Peritoneal disease isn't as common in breast cancer, only seen really in lobular disease, but it is used in GI cancer, and they will do bulky disease, but it's fraught with problems because of intra-abdominal side effects and adhesions. And also it's a terribly moving target. It's really hard. So not so much, certainly not in breast cancer.
Joe, thank you so very much. I hope you can come back next year, 'cause that was great.
Thank you so much. Yes. And I just want to say I'm in awe of every single person in this room. I feel really honoured to be able to be in your presence. So thank you.
And Joe is on the panel later, so if you've got more questions... Oh, you're not!
I've got to go.
Well, we won't. No, we're going to lock the doors because there are lots of people who really would...
Well, you can absolutely email me.
Well, will you come back next year?
Of course. I'd be honoured to.
Thanks very much, everybody.